So my subject or the name of my talk should now be, is there Mrs. Jones, does she exist or not? Yes, the name is too big. Excellent, thank you. Okay, nothing has changed here in the meantime. So thrombectomy. So we are all aware that there are these thrombectomy trials that were positive and changed the field. And I assume not everybody is aware that we have now 9 trials, and additionally we have DAWN and DIFFUSE. So essentially we have 11 trials showing that thrombectomy works, which is pretty impressive. But if you look at the inclusion criteria of the studies, all these trials were designed to show a therapy effect, to play it safe. Majority of the trials were focused on small core proximal occlusion. So it was the best choice at that time. So we actually don't have a good information where the threshold is of therapy benefits. So we discussed this earlier today, and this is coming up for all the guideline questions and the guideline committees. And obviously the recommendation is here in Europe that we recommend that patients with anterior circulation stroke with extensive infarct core aspect smaller than 6 or non-contrast CT scan or core volume larger than 70 mil or 100 mil should be included in a randomized study. We come to this later, but please allow me to make once again the point of the difference between therapy effect and good outcome. And this is based on the data of the SWIFT Prime study. Just to put it very simply on the chart here, if we have thrombectomy and IVTPA together in the SWIFT Prime study with aspect score of 6 to 7, we have good outcome in 43%, aspect score 8 to 10, 67% good outcome. Very obvious. But if we compare this to the non-treatment group, or no, it's not true, to the IVTPA group, sorry, we have almost the same therapy effect. So it's almost the same difference, because also with IVTPA, the patients do worse. So very important point. So if we look at the larger infarcts, and there have been quite a few studies out now, that have studied this based on CT perfusion here, and think this is based on DWI. They compared reperfusion versus no reperfusion, 0 to 50, 50 to 100, 100 to 150. And in all cases, you see a difference between reperfusion outcome and no reperfusion outcome. So it seems to be that even in the group with 100 to 150 mil, there should be a therapy effect, but it's a retrospective study. Numbers are low, but at least it shows this direction. And if we look at Mr. Clean, one of the few studies that actually included larger infarct core patients, we have good outcome in both in patients with smaller than 70 mil and larger than 70 mil, 61%, 47%. But if we compare it to the non-treatment group or control group, we have even an even higher therapy effect if we look at modified ranking scale 0 to 3 in the larger infarct core patients. So there is something going on also in the larger infarct core patients. So it's very important not just to look at the number of good outcome patients, but also on the therapy effect. And if we look at the paper that I already mentioned today in the morning from Bruce Campbell here, if we look at small infarct core and large infarct core, the light green numbers are the number of patients with good outcome. And if you look at it very briefly, just the lower part, you just have 8% good outcome with endovascular therapy and 0% good outcome without, so not a big therapy effect. But if you are more generous with what you expect, you say MRS 0 to 3, you have a difference of 28 versus 8%. And this is not at the expense of patients with modified ranking scale of 5, 4 or 5. This is something that we should always be afraid of, that we are producing patients with a very poor outcome that is almost as bad as being dead. But this is not the case, at least not based on these data. And this is just to also to reiterate something we have mentioned today already. So this is a patient from the early 2000s with a DWI scan. We didn't have thrombectomy at that time. We just did intraarterial TPA. And what you see here is a tiny infarct after carotid T occlusion. It grew after 27 hours to this size. And after 5 days, it looks like this. So still there's infarct growth, at least in the anterior frontal part here. So even beyond 27 hours, what was discussed already, there is infarct growth in selected patients. And it's really hard to predict based on CT perfusion alone what's going to happen with the patient. So on the left side, you see case 1 and case 2 without recanalization. And on the right side, you see case 3 and case 4 with recanalization. And obviously, even in larger infarcts or in larger CBV deficit patients, you can have a therapy effect. And we looked at this more closely by a method called the measurement of net water uptakes. You can quantify the ischemic edema by comparison of the affected region with the contralateral region. Actually, it's a very simple method. It's not very much sophisticated, but you can actually measure the density that is very closely related to the water content in the brain. And this is what we did. And this is, I think, one of the more interesting slides of my talk. What you see here is before thrombectomy in patients with TICI 0 to A and TICI 2B to 3. There's obviously no difference because nothing has happened so far. But after 24 hours, we have a difference in patients with recanalization with a much higher net water uptake than without. That's important because what we are afraid of in patients with large infarcts is typically that we open up everything, that we have a huge water influx, we have a risk of edema growing, and we have a hemorrhage risk. But these data show exactly the opposite. It seems that with reperfusion, we decrease the development of edema, which came a bit of a surprise, and it has been published in March this year. It's a bit more science behind than what I'm able to show you here, but it's a quite interesting observation. The same picture here, but more colorful. And in fact, recanalization decreases edema in large infarcts. So just do it. And if you look at the clinical outcome, which is obviously much more important, same story. So if we compare TICI to B3 100% with 0%, so this is not like a randomized study where you have some degree of success and not. This is just the selection, reperfusion versus no reperfusion. You have a theoretical therapy effect that is actually very, very big in the aspects 3 to 5 patients. So patients with larger infarcts seem to have a therapy effect too. And it's not only us that find this rather strange thing. It's also a very recent study has been published in April stroke, just 2 weeks ago. It was not April 2 weeks ago, but it's still in April stroke. And they did the same thing with 7 large registries. 137 patients out of 2,000 had aspects 0 to 5, and they compared the outcome in these large aspects and in these high aspects and low aspects patients, and there was not a big difference. So there was a therapy effect probably also in the low aspects patients. So all these data suggest that there is something going on in the low aspects range too. This is the first paper that has been published on this based on, again, the Mr. Clean data. And what you see here is obviously we have a considerable therapy effect in the small infarct group, aspects 8 to 10. Nothing really going on in 0 to 4. But if you aggregate this in the HERMES analysis, much more patients, you actually see something. And in a very recent publication from September, they had a look at this here in the lower portion here. And they did it in a very detailed fashion here. And if you look at the aspects 0 to 2, there seems to be no therapy effect whatsoever. This is not a surprise. But if you look at aspects 3 to 5, it seems to be a therapy effect. But what is a bit strange is that the highest therapy effect of all seems to be in aspects 3 patients, but no in 4 and 5 patients. And then it's really hard to believe that this is a really true effect. And maybe it has to do with some patient selection, that they were including only super young patients with aspects 3 that also had other factors that improved the prognosis anyway. So it's still a little unclear. And I think to actually change practice, to really focus also on small infarcts, there's not enough data. For the time being, I don't think we have to do it. We can do it, but we don't have to do it. And we need a randomized trial. I will come back to this a little later. This is another recent observation from our side as well. So what really puzzled me a bit was that theoretically you should think we have an aspect score that is very low. It means that we have very poor collaterals, because it's more or less the same thing. We have good collaterals, high aspect score, poor collaterals, low aspect score. But it seems to be that even in patients with an aspect score of 4 to 5, it's possible to have good collaterals. And if you look at the outcome, it seems to be a differentiating factor to have better collaterals than poorer collaterals in patients with a low aspect score. So low aspect score or non-enhanced CT is modified in terms of treatment effect by the collaterals. And we just did have a look at the collateral score, but it's probably the same thing if we had a look at the perfusion scans. And this effect, again, is modified by age, which is not very surprising. And this carpet is summarizing all of what I was trying to say here. We have the probability of good clinical outcome here. And this is the patient age, and the younger the patient, the higher the chance of good outcome. The older the patient, the lower the chance of good outcome, and the same true for the collateral score. And if you try to walk on this carpet, you can find your patient somewhere in terms of age and collateral score. Everything is more or less connected. And then I'd like to share with you another thought also on the edema. So we were discussing the fast and low progressors. And we have this, let's say we have a patient with an aspect score of 6 after 2 hours and of 6 after 7 hours. Obviously, this is a much faster progressor than this one. But that's not my point here. If we extrapolate this development and we just assume, to make it very simple, that we have a linear relationship here, the theory is, or the hypothesis that we had is, if we have a 60 minutes delay in the early patient, the infarct growth will be much higher than later on. And this is one typical misconception that, or of the old days, that if you are very early, you still have time because you are in the time window. But this is a total nonsense, probably. And if you are later, you seem to have more time here. But is this actually true? Do we have more time if we are later on? Yeah, we looked it up. We looked at the the infarct growth between time of imaging and final scan only in patients with reperfusion, with successful reperfusion, and actually it's the case. So in the acute phase, if we are very early, we have more infarct growth in the same time period than in later time windows. So the hypothesis that we have more time early because we are still in the time window is just wrong. We even have to hurry more in the patient with the same aspect score early than later. So this is the study that I was mentioning already. This is the tension study. And we were having this idea a long time ago already. We were running around, find some funding, but we didn't achieve anything. So we ended up with a very good outcome in terms of funding. We got funding by the European Union, and this is the tension study funded by the European Union. It's a prospective randomized study that randomizes thrombectomy versus best medical care in patients with an aspect score on non-enhanced CT or DWI of 3 to 5 within 12 hours of symptom onset. Up to 700 patients. We were very conservative with our efficacy estimate and typical secondary efficacy endpoints and safety endpoints. And again, you have seen this picture already. The target is not to have patients with a good clinical outcome. This is probably too ambitious, but we want to have an independent outcome. We didn't include aspect 0 to 2, unlike other studies, because we felt that there was too little therapy effect. Inclusion criteria, also the typical ones I think worth mentioning is the age. It was discussed already. Specifically in patients with large infarcts, age plays a huge role because if you have a larger infarct and you have a smaller brain, the same infarct has a larger part of the brain. Yeah? That's one thing. And then the rehab ability of the elderly patients is also lower. So we targeted only patients to 18 to 80 years, and 12 hours after stroke onset was a kind of middle ground. Imaging inclusion criteria, occlusion of the M1 segment, and there is an imaging exclusion criterion. I don't think I have it on the slide here. If the CBV or CBF is larger than aspect score of 3 to 5, it's an exclusion criteria, but this is not mandatory. It's only for the centers that are routinely doing CT perfusion. And to make sure that we have a reasonable inclusion, we developed an online tool for training and testing the sites on reading the aspect score with actually very ugly images, and this is one of them. And there is a training with 10 cases and testing with 20 cases. And the question is, what's the gold standard? And we did this with these old heroes of strokology in Germany. This is my teacher, Hermann Zeumer. He was, in fact, the first person on the planet to do an intra-arterial stroke treatment in the late 70s. So I learned, I owe him a lot of things. And this is Rüdiger von Kummer. Some of you will know him. He was the inventor of the early CTE science, more or less. And this is Martin Benches from Heidelberg, and that's me. So primary endpoint is ordinal MRS outcome, shift analysis, and the key secondary outcomes are a good outcome, modified 0 to 2, and also moderate outcome, as I mentioned, the number of decompressive craniotomies and some other things here. Key issue is also that we expect some qualification from the participating centers, not very surprising, and we don't want to do experimental treatments within the trial. So we expect at least 15 previous procedures with this specific device that is to use. And this is the consortium here. So we have Scandinavia with Norway, Sweden, and Denmark. We have Germany and Austria, but also Czech Republic and Slovakia. For those of you who heard my talk today in the morning, Czechoslovakia is the country in Europe that does the second most thrombectomy procedures per inhabitants. So they are extremely well organized. And then obviously we have France on board, and the Brits are also somehow involved, yeah, but not as participating centers. I don't know if you know this, in the UK in 2015, they did 500 thrombectomies, half as many as Slovakia. It's impressive. So for the time being, we have 19 patients enrolled. We are still in the process of initiating the site, so we are quite positive that we get it done on time. Okay, if I may summarize here, probably there is a therapy effect also in large core patients. It's probably much lower than in small core patients, but we suspect it's there. There are quite a few registries and retrospective case series that suggest that there is something to this hypothesis, but still we need a randomized study to actually confirm that this is true. And if we look at our own patients that we have randomized, it's not at all that we have 100% success rate. So I'm really curious what the outcome with this will be. So the new ESO estimate guidelines say treat aspects 6 to 10, randomize 0 to 5. Recanalization decreases edema, which came as a surprise for us, but it's actually a very robust finding. Same aspects can have different collaterals, different perfusion, and the better the collaterals, the better the outcome. So it's another independent modifying factor. Age is more important with low aspects, and same story as always. If the patient is very early, there is even less time, as I showed you with this small study. Thank you.
Thank you, Jens. And any questions for Professor Fiehler? Are we on with Dr. McTaggart? Any questions for Jens?
Have you noticed like the cases where you guys attempted to do recanalization, but it was failed recanalization, and seeing like early edema or more edema than like people who never got an angiogram?
Okay. That's an interesting question. I never thought about this. So not doing something against not achieving something, right? So yeah, I don't know.
Because I saw a couple of cases where there were like multiple passes and it was unsuccessful, or they tried opening up and that patient ended up getting early edema or ended up getting hemicrania sooner than like typical period of like.
So the study that I was showing, the population of TICI 0 to 2A consisted of patients where we didn't attempt anything or we didn't achieve anything. So it's a mixed population. We didn't split it up. Maybe that's an interesting thing to look at.
Thank you.
So the MR versus the CT low aspects are a little bit different. In that HERMES analysis, most of the benefit in these lower aspect scores was actually from the MR low aspects. It's interesting in tension, you've got both. And clearly you see so much more on an MR than a CT. What do you think about, being able to correlate those two for your trial?
Yeah, that's a good point. I think many of these came from the Thrace study where they had a lot of MRI. So we expect for tension, we introduced MRI predominantly for the French. So we expect the vast majority of patients with non-enhanced CT. And the data that I showed, they were all based on CT, so on non-enhanced CT.
Do you think that for the standardization of the aspects, any tools would be helpful, or you think the clinical exam, the training that you're doing is being pretty good?
Yeah, so I think it's more to get the investigators on board, to actually show them that we also look at the pictures, and they just shouldn't enroll anybody and everybody. I mean, but in the end, it's not a super reliable tool. Absolutely, but essentially the hidden hypothesis behind the whole trial is it doesn't matter too much what you see. So Tudor is even more strict. They include 0 to 5, so for them it doesn't matter any.
But the point that was brought up earlier, the location may be, and the volume in certain eloquent locations may be actually the most relevant part. Is that this is an issue? But my question is more like, if you're going to use aspects, is it reliable to use more tools such as Rapid has now, and the Brainomics, and
yes. So we were discussing this, but we wanted to have our trial as broadly applicable as possible. And because we thought, or we felt, hypothesized that it's not super relevant to have the best evaluation, we decided not to do it. We discussed with the companies, but then decided not to do it. Thank you.
Thank you.